Okay, let's go ahead and get started. Good morning, everyone. And we have another great program this morning. Our first speaker is Dr. Max Mitchell, who's professor of surgery in the CT division and is based at Children's Hospital as a pediatric cardiac surgeon. The talk this morning focuses on advanced MRI and congenital heart disease. By way of introduction, he did his undergraduate training at University of Denver, went to medical school at GW in Washington, and then did his general surgery, cardiothoracic training, and then pediatric cardiac and thoracic fellowship at the University of Colorado. He also went to Royal Children's in Melbourne for 6 months to do more pediatric CT training. He came back on faculty here. He really is a man of many talents. He's retired from the Army Reserve. He's an avid pilot, and if you talk to him, you get a lot of great stories about that. He's an entrepreneur and co-founder of Connex Biomedical. He holds multiple patents, and we meet several times a year, and I'm just astounded by what he's accomplishing in that realm and inventing products that will come into clinical use. He's well published. For the junior faculty and residents, if you have an eye towards being involved in innovation and surgery, I would definitely seek him out as a mentor. He's a great role model. Max, thank you so much for doing this, and we look forward to your talk.
Thank you very much, Dr. Schulich. I appreciate the kind comments you have. I just want to, at the very beginning, acknowledge that this is some work that is a large group of people here over at Children's. And in particular, I've developed a really fantastic working relationship with a young investigator who's now a second-year medical student. And much of what I'm going to show is really his work. So I got into congenital heart surgery because I really love the variety of what we see and the fascinating physiology we see. All of this is possible because of the heart-lung machine. And many, many years ago, one of the forefathers of cardiac surgery is Dr. Denton Cooley, who most of you will have heard of. Dr. Cooley is famous for having said that the heart-lung machine is the can opener that opened up the greatest picnic of all time for surgery. So what I'm going to show you today is a new can opener that is opening up the ability for us to see what goes on inside of a blood vessel or inside of the heart in terms of flow, which has never before been possible. So on the left is a MRI image of a kid with very complex congenital heart disease, where everything is in backwards. This patient has a single ventricle type of anatomy. The apex of the heart is down here on the right side. There's flow coming into the heart through the atrium, a single atrium that passes into this oddly shaped ventricle, passes through a hole into a hypoplastic chamber and out this aorta that is oriented in such an unusual way. So you would predict that the flow through that heart would be very abnormal. And this is an example of what we can do with advanced MRI, where we can literally follow the path line of blood in a chamber into a blood vessel, segmented in any way that we want, and really be able to dissect the flow. And you can really appreciate how abnormal this helical flow in the descending aorta is. So that's just sort of a snapshot of where we're going this morning. So MRI was first developed in the 70s. The first clinical prototype was in 77. Subsequently, the ability to get anatomic data over time was developed in the mid-1980s. This image is an image of a cut-through plane through the heart at the level of the pulmonary artery and the aorta. Now, subsequently, by encoding the data, it was figured out that they could actually map the velocity of blood in a chamber as long as you cut through in an orthogonal plane. Then in the 1990s, the ability to assess blood flow along the path line of a blood vessel was developed. And then in the early 2000s, the concept of what I'm going to talk about today, which is 4D flow, really became possible. It's 4D flow that image that I showed you a moment ago was based on. And then following through into about a decade ago, this was applied to the study of aortic aneurysms. One of my colleagues here at Children's is one of the most foremost investigators who's done this. And then about 4 years ago, the very first applications of 4D flow to congenital heart disease came along, and our group is at the forefront of that ability. So in this image, the anatomy of the blood vessels is depicted by taking multiple sequences over time, and you can actually see the movement of the heart. And most clinical MRI is based on this kind of technology where we're simply looking at anatomy or maybe the movement of anatomy. But if you cut through these blood vessels and you see in the red, yellow, and green circles, blood vessels that are being tracked, you can look at the velocity of blood flow going through that blood vessel. And by knowing the area of that blood vessel, which can be mapped by MRI, you can determine the volume of flow through a structure at any given instant in time. So in the right-hand depiction is a graph of the volume in those 3 blood vessels at any moment in time over a single cardiac cycle. That's 2D phase contrast MRI, which is really what's conventionally used in most clinical work today. 4D flow, on the other hand, is the ability to do this in 3 dimensions at the same time and map that over time. So it's the mapping of velocity in 3 cardinal axes over time that gives us 4D flow. And then by stacking images together in multiple planes a few millimeters apart, we can acquire 3-dimensional pictures of what's going on inside of a heart. So this is an example of whole heart 4D flow MRI. Now, the colors represent the path lines of blood flow. And you can see that you could visualize this as following a single red blood cell. So with MRI, you can track a blood cell from the apex of the left ventricle as it goes out the aorta. And each one of those particles is velocity encoded so that we can tell the relative movement of particles one to another. Now, for clinical, that's very useful for clinical, but for more research purposes, we really want to be able to cone in on a single structure. So using the sophisticated computer software and computer hardware that we have, we can overlay a standard cine image of the anatomy on a blood vessel that's isolated with the path line. So this is an example. Sorry, I got off on my slides. Give me just a second. This is an example of how we can encode to simply look at the aorta. This is a patient with hypoplastic left heart syndrome, has had an aortic arch reconstruction, and you can see that this is very perturbed abnormal flow, because in the normal person, it would be a much more linear path line across the aortic arch. So there are many, many things we can do with 4D flow. In congenital heart disease, patients typically or very commonly have connections between the right side and the left side of the heart. So they have variations in pulmonary blood flow and systemic blood flow. And up until now, you'd have to do a heart catheterization to determine that ratio, which is very important in assessing how a patient's doing. But we can do that with MRI now using 4D flow. Other things we can do is we can look at vessel wall properties, in particular wall shear stress, which is an important mediator of vascular remodeling. We can look at energetics of flow, following how much energy is lost as blood passes across a blood vessel. One of the indices that was actually pioneered by my colleague Michael Schaefer is vorticity. And we've used vorticity to look at why we have perturbations of flow in lesions like tetralogy of flow and in pulmonary hypertension. And another very recent parameter we've been looking at is ventricular volume partitioning. And I'm going to give you some examples of that. Suffice it to say, this relies on very high-end mathematical calculations. I like to call this Michael Schaefer math because even though I minored in math in college, I have no idea what this means. I know what that means because I can see that anatomically. So I'm going to go through 3 examples, if we have time to get there, of some of the work that we've done using some of these parameters that I just showed. In my field, the Journal of Thoracic and Cardiovascular Surgery is really the preeminent journal for congenital heart surgeons to publish in. And over the last 3 years, we've made the cover of 3 of these, of their journals with some of our work. And I'm going to show you these 3 studies as we go forward. So tetralogy of flow is a very common lesion. I think most of you will have heard of it. To review, these patients have a ventricular septal defect. They have a narrowed right ventricular outflow tract, particularly at the pulmonary valve. The reason this happens is that the aorta and the pulmonary artery don't form normally, and the aorta is pushed out over the right ventricle, crowding the pulmonary artery, which leads to pulmonary stenosis. And then the 4th part of what was described as right ventricular hypertrophy, which is really a secondary phenomenon due to the obstruction at the pulmonary valve and the VSD that subjects the right ventricle to left ventricular pressure. Now, the first repair of this was done in the 1950s by Dr. Lillihei using cross circulation. And many of you would be familiar with that. And the operation that he did is essentially the same one that we do today. We close the ventricle, the VSD, through a hole made in the right ventricle. And depending on the size of the pulmonary valve, we cut all the way across the right ventricular outflow tract into the pulmonary artery and put a patch. We call that a transannular patch. That relieves the obstruction, but unfortunately, this results in wide open pulmonary insufficiency, which is why these patients become annuities for congenital heart surgeons, because they require multiple operations throughout their lives due to the pulmonary insufficiency. So one of the problems and one of the controversies in congenital heart surgery is, when should we do a pulmonary valve replacement? And practice in this is variable and highly controversial as to what the indications for that would be. I need to back up, Michael. How do I do that? One of the things that is not described in congenital heart or in tetralogy of flow, which is another abnormality, is the size of the aorta. If you look at a baby, even in utero, if they have significant pulmonary stenosis, they're going to have a very large aorta, usually twice the normal size. And that's because in a baby, where there's flow, there's growth. If something has blood flow, it's going to grow. So we got interested in looking at the left side of the heart in tetralogy because the vast majority of clinical follow-up is guided towards the right ventricle because of the pulmonary insufficiency. But it's known that these patients develop left ventricular problems late in life, and that leads to mortality. And one of the reasons that happens is that they have aortopathies. Now, it's known that that patients that are older with tetralogy of flow have aortic histology that's similar to Marfan's disease with medial degeneration. But most of these studies, if not all, have been done in patients who were older at the time of their repair. We recently came across this article by Francois that demonstrates that if you repair a baby in the infancy, meaning under a year of age, that the aortic size will actually normalize by the time the baby, or by the time the patient is 7 years of age. So we wondered, well, if the aorta remodels and reduces in size, what is the function like? Are they still going to have pathologic aortas, or is the aorta going to be normal? So the objective of this study was to determine if normalized aortic size in repaired TET patients who repaired at under a year of age, which is now what we commonly do, is associated with normal vessel wall parameters and flow parameters. So wall shear stress is a major mediator of vascular remodeling. If you have too high or too low shear stress, the endothelium has signaling into the media that causes remodeling. And it's typical, and if that wall shear stress is high or low, it leads to pathology, and is one of the primary governors of aortic pathology and also pulmonary artery pathology. So What we did in this study is we looked at control normals in the same age range as a series of tetralogy patients. So this is an example of the 40 flow acquired path lines of blood flow in the aorta of a normal. On the right is a heat map of wall shear stress, which can be calculated with the MRI machine. And the heat map shows where stress is greatest, with red being the highest. And this is normal to have this in the descending aorta because of the progressive caliber decrease. Blood flow has to accelerate, and that increases wall shear stress. On the left is a video representation of the path lines in a typical tetralogy patient. And what we observed was this very chaotic vortex and helical flow formation in the ascending aorta. Now, on the right, what we did was we looked at this at various levels through the path line of the aorta in both normals and controls. And we found that the wall shear stress, whether we looked at peak or time average, was significantly higher in every segment of the aorta we looked at in the tetralogy patients versus the control. And mind you, these are kids. These are patients that ranged in age from around 4 to about 15 with a mean age of about 10, compared to controls in the same age range. In the bottom frames, we looked at velocity encoding. So this is mean intensity projection, which is a code for velocity mapped through the entire aorta. And you can see that in the tetralogy patient, there's higher velocity in the ascending aorta and in the proximal descending aorta. This is wall shear stress on the right. So comparing the tetralogy on top to the control on bottom, and these are typical, you can see that were significant differences in the tetralogy patients. So the clinical implications of this were that even though the aorta normalized in these children, it remained pathologic, and the properties of this are pathologic. So it is not likely that they are going to be free of the consequences of a stiff aorta subsequent in life, which leads to increased afterload on the left ventricle, aortic valvular disease, and the potential for aortic dissection. So the current crop of patients that are being done still need to be followed throughout life for those potential pathologies. The next study I want to move into is our second study, or is one of our other studies on tetralogy of flow, and this is where we looked at volume partitioning. Now, I mentioned a bit ago that when we cut across that pulmonary valve, we cause pulmonary insufficiency. So one of the issues in management of these patients over time is replacing the pulmonary valve, and timing that is difficult. This is a whole heart 40 flow MRI of a patient with tetralogy. And what I want to point out is this regurgitant jet you see coming back through the pulmonary valve here. This is what we get. Now, when you develop pulmonary insufficiency, the heart responds to that. And the response is for the right ventricle to dilate. Essentially, it has to generate a larger stroke volume in order to make up for the blood coming backwards. So you get 2 steps forward because of the 1 step backwards, as an analogy. Now, pulmonary valve replacement is almost always done with a bioprosthetic valve, and the lifespan of a bioprosthetic valve is very short. So timing of when to do this is controversial because there's risk in doing these surgeries. So we don't just go do this right away. We wait for them to develop right ventricular problems. The question is, how much right ventricular problem should trigger an operation? Well, that's a very controversial question, and there's really no good parameter to guide this. So what we wanted to do was try to figure out if we could look for parameters that could help guide this. Now, one of the things that's sort of intuitively obvious is that the right ventricle and the left ventricle share a common wall, a septum. So they're hooked together. And it makes sense that if the right ventricle has trouble, it's probably going to impact the left ventricle. So the objective of this study was to use 40 flow MRI to look at the volumes inside the left ventricle in patients with tetralogy of flow to see if we could find parameters that could be helpful in determining when we should go on to pulmonary valve replacement. So this is a representation of what's happening inside the left ventricle during a single cardiac cycle. Previously, other investigators determined with 4D flow that they could partition the blood inside the left ventricle into components that make up the stroke volume of a given heartbeat. They were able to partition that volume into 4 separate components. In green is direct flow. So direct flow is flow coming through the mitral valve that gets ejected directly out the aorta in the same cardiac cycle. This is the most efficient flow. Blue flow is retained inflow. This is flow that came into the ventricle in the previous cardiac cycle and then got ejected out the aorta. In red is residual volume. This is blood that just sits inside the left ventricle and continues to recirculate. And with 4D flow, you can code each one of those components into the partition that it belongs to. The other thing is that other investigators have determined that these components can be related to function. And it's been determined that the relative percentages of these components is impacted by diseases such as cardiomyopathy and ischemic cardiac disease. So what we decided to do was to partition tetralogies and controls and compare them. And what we found was that in the control patient, direct flow represented about 35% of the blood flow ejected during a given heartbeat, and residual volume was about 15%. In tetralogy patients, these two parameters were substantially different, with less direct flow and more residual volume. So this is the most efficient flow, this is the least efficient flow. Now, we also chose patients that were relatively early in their disease process, because these were patients who had right ventricular volumes well under what we typically have considered the threshold for pulmonary valve replacement. So our hope with this is that we could end up using these kind of parameters to help guide a triggering point for when to do a pulmonary valve replacement. Because when we operate at this level, we reduce right ventricular volume by stopping the pulmonary insufficiency, but we don't restore right ventricular function to normal. By knowing that left ventricular function is already impacted, we have an earlier indicator of heart problems. And so the clinical implication of this is that what we need to do is a study of patients where we operate on them earlier and do a pulmonary valve replacement and determine if we can restore left ventricular function to normal with that. The graphs on the right, I'm not going to go through the details, but essentially what they show is that the left ventricular function is related to right ventricular volume, and that when we have a large right ventricle, we have an impact on the left ventricle. One of the gratifying things in the work that we've done is demonstrated in this paper. This paper just came out in Pediatric Cardiology. Now, we have published 4 4D flow MRI-based papers on tetralogy of flow, and we were the first to ever look at this. And all of the studies that we did were recapitulated by this group from Japan, which demonstrated that we were right in what we showed. And the other thing that this paper showed was that, going back to the aortic stress paper, the patients with tetralogy who got repaired early in life in our study were all very young. These guys studied much older patients and found that even though those patients were repaired in infancy and had smaller aortas, they actually had higher wall stress than the older patients who had larger aortas. So again, confirming that the tetralogy patients are likely to have a lot of trouble in the future on the left side. For the last part of the talk, I want to go to another lesion that's one of the most complex, most difficult lesions we deal with. And this is hypoplastic left heart syndrome. This is the #1 cause of infant mortality in the United States. About 2,000 babies a year are born with this disease. And up until the last 2 decades or so, it was essentially an untreatable disease. A guy named Dr. Norwood in the 1980s began to pioneer how to deal with this. So in hypoplastic left heart syndrome, you don't really have a left ventricle that can work. You don't have an aorta that can work. And all of the blood comes into the heart, goes through the pulmonary artery. The systemic flow is dependent on the ductus. Blood flow to the heart comes backwards down this tiny ascending aorta, and blood flow to the body goes antegrade down the aorta. And the pulmonary artery and aortic circulations are essentially in parallel. This is very precarious hemodynamics and anatomy. Dr. Norwood conceived of an operation in which the aorta is amalgamated to the pulmonary artery and valve. The ascending aorta and arch are augmented with a large patch, and then pulmonary blood flow is supplied through a shunt to the pulmonary artery. This is the stage 1 Norwood procedure. This is really the operation that is now the definer of what the performance of a given center is. In the current era, the mortality for this operation is still about 10% in the best performing centers, of which our center is one of those. Now, there are 2 more stages involved in treating these patients, where the heart is simply or venous return to the heart from the body is bypassing the heart directly into the pulmonary artery in a series of operations, so that when you end up at the end of palliation, all of the systemic venous blood goes directly into the lungs without being pumped through the heart. And the one good ventricle, which in this case is the right ventricle, is used to do the work of the heart for the systemic circulation. Well, this whole thing depends on good hemodynamics. Now, in the upper right corner is a picture of what made the cover of JTCVS. And commonly, surgeons would oversize the aortic reconstruction to allow for growth potential. But we thought that that was probably a mistake. And what we wanted to do was use 4D flow to look at the energetics of flow across the arch and see what the optimal geometry ought to be for a Norwood arch reconstruction. So what we did is we took 16 patients with tetralogy of flow and divided them into 2 groups based on the degree of tapering across the arch. So we looked at the diameter of the aorta and then the progression of decrease of the diameter, and divided them into patients with high degree of tapering, which would be essentially an oversized arch or ascending aorta, and patients that had a more normal appearing conformation of the arch. And we compared their viscous energy loss across that pathway using 4D flow MRI. So if you have a particle that takes a direct route, it's just intuitively obvious that that's going to have a lower energy requirement than a particle that has to take a very circuitous route. So in red, that's a direct particle flow point. Compare that to a particle of blood that has to take a very helical or vortex-like pathway through the same trajectory, and you have a different degree of energy loss across that pathway. So we can map that with 4D flow MRI and come up with the difference. That's the basics of what we did in this study. And what we found was, regardless of whether we normalized cardiac output, so let me back up for a minute. At the top, in the top graph, we are comparing the high degree tapering patients to the low degree patients across the ascending aorta. Then we're doing it from the ascending into the arch and from the ascending all the way into the descending aorta. And every one of these, the gross number of viscous energy loss was significantly higher in the high degree tapering group. But this was a range of ages and sizes. So we normalized this data to cardiac output and to stroke volume, and found the same trend, demonstrating that the high degree tapering arch was suboptimal in energy utilization.
Max, I just want to give you a 2-minute warning here.
I think we can wrap it up in that time. Great. So essentially what we found was very abnormal flow in those patients. And we were able to map out what would really be the optimal type of anatomy, which is to, not surprisingly, try to duplicate normal anatomy. So over the last several years, this has been an extremely productive endeavor on the part of my colleagues and I here at Children's. I think our group is clearly amongst the most respected groups in using advanced MRI in the study of congenital heart disease. I need to thank my colleague, Michael Schaefer. Michael, I met when he was finishing his PhD in biomedical engineering. He's really the brains behind this entire program. Michael's now a second-year medical student. So if you just think about the number of papers I showed you, for a guy that's in medical school to be able to keep up with that is truly extraordinary. And then I want to thank the Rady family. The funding that has allowed us to do this has largely come from the Rady family, and I really appreciate their generosity. And with that, if there's any time for questions, I'm happy to entertain them.
Yeah. We'll have people either email you
Okay.
or call you, but please, for the junior faculty and other and trainees, Dr. Mitchell is a great example of somebody who is extremely successful in clinical surgery, but also has really organized the resources of a campus to build a personal research program and also to build companies and really invent things that will affect clinical care. So please reach out to him. And great talk, and thank you so much.
Thank you.